everybody, and welcome to Voices of Wisdom, TIRO's podcast, designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. You can think of it as kind of a fireside chat where we talk to international experts who share their wisdom and offer practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartl. I'm a head and neck surgeon at the Gustave Roussy Cancer Center in France, and I am very excited to be your host of TIRO's Voices of Wisdom podcast. I will be hosting this second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasieka, who pioneered these podcasts. I want to take this opportunity to thank Janice for all of her hard work on making these podcasts a reality, and congratulate Janice and all of those who contributed to the success that they have become. In each podcast, we will be meeting with one or several international thyroid experts, and each episode will dive into a specific topic related to thyroid cancer care. Our aim is to help clinicians deal with issues that are often complex, and our aim is to provide as much evidence-based information as possible, but also practice-based information and tips from world-renowned experts. In each episode, I'm joined by a distinguished international guest who brings their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, a pathologist, a medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients.
Welcome back to part 2 of this special episode of Voices of Wisdom. If you're just joining us, we're continuing our discussion on unresectable thyroid cancer and advanced lesions with Dr. Mark Zafereo. If you haven't listened to part 1 yet, I highly recommend going back to catch the first half of our conversation. Without further ado, let's dive back into part 2 with Dr. Zafereo. Wow, that's really interesting. As surgeons, we're like, oh no, the patient has distant metastases, so it's not worth doing the local surgery. That was sort of something that we grew up, quote unquote, learning, sort of a paradigm. So this is a paradigm shift too, is operating on patients who do have distant metastases that are stable. And so the surgery would be to limit local regional complications.
Yeah, that's a great question. As you would imagine, it depends on the biology of the disease. So I think here we're specifically talking about anaplastic thyroid cancer. And if they have small burden distant metastatic disease and it's controlled, for example, it's not uncommon with an ATC patient to have a complete metabolic response. You have a very local regionally advanced tumor, you have some distant metastases, and you put the patient on the dabrafenib, trametinib, and pembrolizumab, and you get a complete metabolic response. Well, in that case, we're going to do surgery. You can have another example where you have some response, but you still got some very small burden of distant disease, and we're probably going to do surgery on that patient too, because that disease can hopefully be controlled for some years, at least. Typically, in those cases, the large burden of disease is in the neck. And so that's really the risk. So as we know, these patients with anaplastic thyroid cancer, they commonly and often quickly develop resistance. And so when they do develop resistance, if the majority and the large burden of disease is in their neck, that's where they're going to get in trouble first. And so that's a situation where we would go ahead and do surgery, even in the presence of distant metastatic disease. But it is, it's a judgment call. You have to look at each of these cases critically. The more the patient has distant disease, the more you want to be sure that you're limiting the morbidity of the surgery, right? I mean, so nerve sacrifice, and certainly anything like if you were ever going to do a laryngectomy or something like that, you've got to really consider distant disease, and is the distant disease controlled, or is there distant disease before adding morbidity to a surgery? So those are some other principles that we consider.
Yeah. So again, multidisciplinary tumor board discussion kind of regularly. So you said you looked at after every 2 cycles. So the nadir for you, the point where you're going to get the best local response, in your opinion, is after 2 cycles, after 4 cycles, something like that? Is there a general rule to when you think they're going to be operable?
So with ATC, they're thinking about this in terms of 3-week cycles. We do our initial imaging after 2 cycles. And after that second cycle, when we look at that imaging, we're starting to consider whether or not we're going to do surgery. And if we are going to do surgery, planning the surgery, because if they're a patient who has had a fairly rapid and dramatic response, and we are going to do surgery, typically we'll move to do it at that time. So it's not that they may get one more cycle, so they may get a third cycle, but we'll be going ahead and scheduling and planning the surgery, because these surgeries often take several weeks to get them to the operating room in terms of scheduling. So often after 2 cycles at that visit where we get that first imaging study, we are making a decision about surgery. And it's because if you do get a rapid and dramatic response, you want to capitalize on that and not give that tumor a chance to develop resistance. And so that's why we're typically, with anaplastic thyroid cancer, making a more quick decision for surgery. And that's very different than sort of necessarily the time frame for other types of less aggressive, although they still could be local regionally advanced, but less biologically aggressive tumors.
Great. So it's really kind of delicate. You really have to be on the ball and be watching these patients and getting them to the OR. And timing, I think, is of the utmost importance. That's really very important to note, that the surgeons and the oncologists really need to work together in tandem on these. I guess maybe a quick question about, you talked about the structures that need to be freed up from the tumor when there's a response. And you talked about the recurrent nerve where it's difficult. Do you have a tip or a modality for looking at the esophageal mucosa and the muscle, and how to evaluate that kind of involvement? Because that's kind of hard to do on imaging, kind of like the prevertebral fascia is hard to evaluate on imaging. The esophagus seems to be kind of a sticking point. Do you have any comments or tips on that?
Great question. And the first thing I would think about in terms of esophageal invasion or not is the patient having dysphagia? If the patient is having significant dysphagia, like the food is just getting stuck and it won't go down, oftentimes if it's equivocal on the imaging, that can mean that the tumor could be inside the lumen of the esophagus, and you certainly have to be prepared for a more extensive surgery. But if the patient's not having the symptom of dysphagia, it doesn't mean that it couldn't be intraluminal, but most often it's just going to be, if it's involving the esophagus, if they're not having dysphagia, most often it's just going to be involving the muscularis layer. So studying the imaging carefully is important. Sometimes even CT imaging, but sometimes even a PET scan can help, especially if the patient has had neoadjuvant therapy, because you want to see, in terms of residual tumor, what's actually FDG avid tumor and what just may be just kind of scar tissue and such. So a PET scan can also be helpful in correlating that with the CT scan and trying sort of looking at that together and trying to see, what is just kind of scar tissue and from the treatment response and what is going to be FDG avid disease, which would definitely need to be resected. So I do a lot of esophageal muscularis resection. Usually there's not too much morbidity with that. I think that's generally an intraoperative. I mean, you're going to have an idea based on the imaging, but a lot of that's going to be an intraoperative assessment and trying to see if the tumor looks like it's invading the muscularis. I don't think there's a lot of morbidity with in most cases with removing a segment of the muscularis. But at the same time, if you have a patient who's been treated neoadjuvantly, let's say it was a tumor that was very much looking like it was invasive of the esophagus, and they've had a very good response. And the PET of this, it doesn't look like it's PET avid at that esophageal interface. We're not going to resect esophageal muscularis in that case. Where when you do the surgery, there's certainly going to be some fibrosis there at that interface, but we're going to assume, because the PET scan is negative, that fibrosis does not represent active tumor, and we're not going to undergo the potential morbidity of that, even that esophageal muscularis resection, because most of the time when we're doing esophageal muscularis resections, it works out well, but there's always the possibility when you thin the esophagus and you're just left with mucosa that you can get a leak, and that can be a pretty significant complication that can take the patient a while to recover. So we don't want to do that type of muscularis resection unnecessarily. But if there is tumor there, it needs to be done, because if you leave residual FDG avid tumor in the esophageal muscularis, then that's going to be the interface that causes a problem for the patient going forward.
I think that's a pearl of wisdom. It's really important. You're looking at the PET scan and what's avid to see really what you're resecting, because that sort of dovetails with my next question was, when you're in there, is it more difficult than upfront surgery in a quote unquote normal patient after neoadjuvant treatment? And can you tell the difference between what's fibrosis and less active cancer? So is it more difficult, and can you really make that difference, or do you really have to go on the imaging, the PET imaging?
Yeah, I think those are both great questions. And the answer to the first question, yes, it is. It is a bit more difficult. It's oftentimes not as difficult as it would have been if you didn't have neoadjuvant therapy, because in that case, obviously, the tumor may not have even been resectable, or it may have been significantly morbid for the patient. But it is a little bit more difficult. The general rule is the more response that you have. So the better the response, the more inflammation and fibrosis that's going to be created as a result of that response. And so, and then to answer the second question in terms of can you tell what's active tumor and what's not? I think to some extent you can. You get a sense of you get a sense of what's fibrosis and what looks like active tumor, but that's certainly not foolproof. I think you definitely want to have the advantage of having looked at the imaging, and especially the PET scan. If I see, a PET scan where there's been a complete metabolic response, or only, a small focus of residual FDG activity, and it's not, up against the esophagus or right in the tracheoesophageal groove, I'm definitely not going to be resecting muscularis or sacrificing the nerve in that case, because I know that that's likely just a lot of fibrosis and not active tumor. So in most cases, you should be able to preserve the recurrent laryngeal nerve. Definitely not in all cases. There's certainly cases where, especially if the patient doesn't have an ideal response, I mean, you certainly may have to resect the nerve. But if that nerve is functional and there's not FDG avid tumor that's right in the groove on that nerve, and you're certainly not going to resect a nerve because of fibrosis. So as you would do with any other surgery, you typically would try to find the nerve, low in the neck, away from where a lot of the fibrosis is going to be, and you follow it up just like you would do in a recurrent case where there's a lot of scar tissue. You find it really low as possible in the central compartment. You follow it up, and oftentimes you'll have to dissect it through some fibrosis, but it'll come off of there, and then you take everything on top of the nerve, and then that's an ideal outcome because you save the nerve and reduce morbidity for the patient.
Well, and then of course, in these cases, we're going to be using neuromonitoring to be able to trace that nerve eventually in that block of fibrotic tissue. That's really interesting. Okay, Mark, I'm going to ask a question for anaplastic. Do you think, is it the surgery for you that changes it, or is it the fact that you're changing the biology of the tumor with the BRAF and MEK inhibitors that has changed the prognosis? The fact that you resect the tumor, or the fact that the tumor responds to become resectable?
I think it's both, but I think most of the success that we've had with anaplastic thyroid cancer has been, the fact that we've identified targets and we have drugs to target those mutations. I mean, there's no question that is most of the reason for the success. But it's obviously there's a big picture here, right? In the big picture, that success, particularly with anaplastic thyroid cancer, when we can identify a targetable mutation, we put the patient on that drug, and the patient has a significant response, that's often not a long-lasting response. Sometimes it is, but it's often not. And so you often need something else to try to prolong disease control in those patients. And that's where the surgery does add something. So is most of the prognosis and the improvement in survival related to surgery? No, of course not. It's mostly related to the advances in systemic therapy and immunotherapy. But surgery is a tool that does help in a lot of patients. I mean, there's plenty of patients where they come in with massive neck tumors. They have a dramatic and rapid response. They have a little bit of PET avid disease that's left there, focally. We do a surgery. We get that out. We put them back on the drug, and they do well long term. That's not every patient. Not every patient's going to have that type of ideal response and long-term disease control, but there's many patients who do. And so those patients are with a combination of the systemic therapy and often surgery. So I think the systemic therapy is most of it, but the surgery adds an important element of disease control for many patients. And in terms of advances going forward with aggressive thyroid cancers in anaplastic and other poorly differentiated is going to come in the systemic therapy realm. I mean, there's no question. I mean, we're not going to foreseeably invent some kind of better surgical technique that's necessarily going to better be able to remove tumor. It's probably going to be that we develop better drugs and agents that tumors respond to better. But I think surgery will continue, at least for the foreseeable future, to play a role because these drugs, unfortunately, don't work perfectly and they don't work long term well in many patients. And so surgery is an important part of that more intermediate or long-term disease control.
I think that's really great what you said about the big picture and the long term. And it's true that you can really have fistulas and bleeding when you still have tumor in the neck, and as we all know. In the beginning, you were talking about the neoadjuvant, in the neoadjuvant setting, using neoadjuvant therapy to make an unresectable tumor resectable, or make a resectable tumor resectable with less morbidity. And the question is that the concept, and I'm not talking about anaplastic necessarily, I'm talking about differentiated or medullary. The concept of preserving a recurrent laryngeal nerve by using neoadjuvant therapy has been proposed. And my question is these drugs do have some toxicity. My question is, just for preserving a recurrent laryngeal nerve, do you think the toxicity profile of these kinase inhibitors warrants that kind of treatment?
I think you have to look at the biology of the tumor to answer that question and to fully. So with anaplastic thyroid cancer, so this is a life-threatening disease, rapidly growing tumor. You're going to put those patients on these drugs regardless. And in those patients, we have seen a few examples. We published this in Video Endocrinology with the preoperative and the postoperative laryngoscopies and the preoperative and postoperative imaging, showing that we have seen some patients who have had even return of function where the nerve is not moving initially, and then after treatment it's moving again, and we're able to preserve that nerve. So in those cases, it's probably what you see with lymphoma. Anytime you have a tumor that's very rapidly growing, then it probably is really compressing that nerve and really causing it. But it hasn't yet permanently damaged that nerve. And if you can arrest it at that point and get it to shrink back down quickly, you can potentially save that nerve. I think that's a unique situation to a fast-growing tumor. So with ATC, I think it's clear that there's a potential benefit. I think when you're looking at tumors that are less biologically aggressive, differentiated thyroid cancers, medullary thyroid cancers, the first thing you have to look at is this a targetable mutation? And if it is, do you need to do systemic therapy for some other reason like distant disease? And if the answer to that is no, and it's really only the local regionally advanced disease that you have, and you're making a decision about whether or not to use the neoadjuvant therapy for the local regionally advanced disease, that's a judgment call. I don't think, and this is my opinion based on what I've seen in a lot of patients, I don't think in a less aggressive, in a differentiated thyroid cancer population, or in a medullary thyroid cancer population, in a population where it's not rapid growth, where it's doubling weekly, where it's more of a growth that's probably been happening over months or even sometimes years, that takes out a nerve, for example, I don't think you're going to see recovery of nerve function with any type of neoadjuvant approach. I've never seen that, to be honest. And so if that nerve is out, you're not going to salvage that nerve in a DTC or an MTC patient with neoadjuvant therapy. The question then becomes, well, what if the nerve is not out, but there's significant disease, in the tracheoesophageal groove, and that's a judgment call. I can't say that I have a perfect answer to that. Fortunately, For DTC and MTC, let's say, for example, you have a targetable fusion, like for a DTC patient with a RET fusion, that's a single agent drug. It'd be a RET specific inhibitor, or in an MTC with a RET mutation, it'd be a single agent drug, RET specific inhibitor. And those do have some side effects, but it's not like the side effects you would see with like triplet therapy for ATC. So I think that's an area where we need further study and experience. But if you've got significant extrathyroidal disease, or less commonly extranodal disease, we are using it, neoadjuvant, to try to reduce morbidity in those cases. Now, you're not going to do it just if you've got a big tumor that's confined to the thyroid, or just big bulky lymph nodes. That doesn't really justify it, right? Because the morbidity of that surgery is going to be exactly the same whether or not you shrink it. Even if you have a good response, which using a RET specific inhibitor, like a 50% response would be a really good response in that case. So even if you have a really good response, you're not fundamentally changing the nature of the tumor. So you definitely need to have evidence of extrathyroidal extension, on the scan, or extranodal extension that is threatening an organ. And commonly, as you alluded to, it is going to be the recurrent laryngeal nerve and that tracheoesophageal groove. And it is, at this time, it's a judgment call to whether or not you think shrinking that disease by, and so you look at the target, you look at the drug, you see what percentage shrinkage are we commonly going to get. With the RET specific inhibitor, it may average 35% shrinkage. Will that potentially help me putting that patient on that drug for 6 months and then doing the surgery? And in some cases, we're saying yes. In other cases, we say no. It certainly depends on the individual circumstances of the disease and the patient.
Thank you, Mark. So it's a case-by-case basis, weighing the risks and the benefits, and maybe saying that this might also improve surgical margins, where you'd be less R1 and maybe more R0. So those are tough calls. Well, thank you for your opinion on that and giving us your wisdom on that. So how do you see the future of neoadjuvant therapy in general, or anaplastic?
I think it's an exciting time. I think there's two elements to the future. One is that there's going to be new things. And I think those are very likely going to come in the terms of new drugs, new drug combinations, whether that be, TKIs, whether it be immunotherapy, or some other type of systemic based therapy. And so I think continuing to be open to, advances in terms of systemic therapy, and then how surgery can be integrated with those advances in systemic therapy, I think is an exciting part of the future. And then I think for what we have right now in 2025, let's say we're not looking to the future, we're just saying for what we have right now, I think it's just continuing to study the approaches that we have. And I think it's very clear to me, in my opinion at this point, that for anaplastic thyroid cancer, a neoadjuvant approach followed by surgery, especially if you can limit the morbidity of the surgery, it makes a lot of sense. And that's worked very well for us. We've had very good outcomes. We've improved survival. I think for other types of cancer, it's not, the results are not as dramatic, and it requires a bit more study. I think we're studying, medullary cancers that are RET mutated in clinical trials. We're studying differentiated thyroid cancers, that some of which have, RET fusions or mutation agnostic use of neoadjuvant therapy. I think that requires more study. I think that's going to be a bit more subjective in some cases. There's, how do you measure success in those clinical trials in those situations? I think we're continuing to study that, and I think over time, hopefully, we'll continue to have a better understanding of that. So those are a couple of comments I would make about the future, the present and the future, I should say.
And with the comment then to try to get patients into clinical trials as much as possible, or to our databases, so that we get more objective information on this. Thank you, Mark, so much. So in addition to all these pearls of wisdom, do you have another take-home message, anything?
I think it's an exciting time. I think a few principles I always try to keep in mind. This is beyond just a clinical judgment of a surgeon, but do unto others as you would have them do unto you. I mean, the patient that questions most commonly asked is, what would you do for your mom or dad or your brother or sister or your wife or husband or whatever? I think always going back to that and trying to really critically think about that. What would I do if it were me or my wife? As we study these things, we want to push the envelope some, but we don't want to go overboard, right? We want to remain objective. So I think that's a important principle for us all to kind of keep in mind as we continue to study these issues. So I think those are two of the things: is kind of do what you would for a patient, what you would want for yourself, and but we do need to be willing to push the envelope a bit. And we know that medicine and science and the treatment of disease is not always perfect. We're not going to win every battle, unfortunately, especially when we're dealing with very advanced disease. So, but trying to keep an overall positive outlook and cherish the successes and try to learn from our failures.
That's a wonderful take-home message, Mark. Thank you. It goes straight to my heart, and I hope to the hearts of our listeners.
Well, I've learned so much from you, Dana, and from all of our colleagues at TIRO over the years, and look forward to continuing to listen and learn from these TIRO podcasts.
And that concludes our extended conversation on unresectable thyroid cancer and evolving strategies to improve patient outcomes, particularly with neoadjuvant treatments.
If you have any questions or suggestions for future podcasts, please don't hesitate to email us at voicesofwisdompodcast@gmail.com. We have an exciting season coming up. Please stay tuned for future episodes. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time. TIRO Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. So just visit tyro.expert/subscribe or click in the link in the description.
I'm Dr. Dana Hartl, and it's been a privilege to explore this critical topic with Dr. Mark Zafereo, and to be able to hear from his experience in these rare diseases that are so difficult to treat. Mark, thank you again for sharing your expertise and shedding light on the advancements that are so exciting in this field.